Hello, I'm Dr. Lenore Walker, and today we're going to talk about domestic violence and what's new and what's been around for a while in 2012. So we're going to start this morning with trying to learn a little bit about what is domestic violence. Now, we've known for a long time that domestic violence is any physical, sexual, or psychological abuse, including threats, stalking, surveillance, that's committed by one person against another person in order to get them to do what it is that person wants them to do without any regard for their rights in the situation. The goal is usually to control the other person. It's the intention of getting the victim to do what the perpetrator wants the victim to do, without regard for the victim's rights. Throughout this webinar, I'm going to use the term victim and perpetrator. And sometimes I may even use the pronouns she to define the victim and he to define the perpetrator. We know that it's not always men who are the perpetrator and not always women who are the victims. But it's so frequent that we tend to use those pronouns with your understanding. So the bottom line is that domestic violence is an abuse of power and control. Often occurs with other kinds of gender violence. For example, sexual abuse or violence against children, sexual abuse against children, or other kinds of sexual exploitation. Again, women are more likely to be the victim and men are more likely to be the perpetrator in these types of gender violence crimes. This also includes the kind of sexual exploitation that we're now looking at in sexual trafficking, but that's for another webinar. So what are some of the domestic violence methods that we want to know about? Well, we want to learn about isolation of the victim. We want to learn about negative commands, put-downs, cursing, name-calling, harassment, surveillance and stalking, as I mentioned earlier, threats to harm himself, threats to harm the victim, and threats to harm other people, intrusive behavior, looking over her shoulder, telling her what to do all the time. Financial control, trying to take control of the money, no matter who earns it. Obsessive kinds of demands, making sure that everything is just the way he wants it to be. Sleep interruption, oftentimes yelling and screaming and ranting and raving so that the victim doesn't get adequate sleep and doesn't have the psychological or physical energy to deal with the next day's worth of work. He may also interfere with parenting of children. We'll talk more about children later on. Physical abuse, of course, and then sexual abuse, which we don't often talk a lot about. We spend much more time on the physical abuse, but we know in many cases the sexual abuse is humiliating, shameful, and often causes the victim an enormous amount of psychological damage. So who are these perpetrators? Well, again, as I said earlier, the gender tells us 95 out of 100 perpetrators that we know about are men. They come across all demographic groups, all educational levels. Some have committed other kinds of criminal behaviors. Some are not known to have done that. Some are only rude to women. Others may be rude to everyone. They may be bullies. They may be sex perverts. Some are noticeable. You know them when you see them. But others, you wouldn't know that underneath or beneath those closed doors what goes on. All try to get power and control in different areas. And if they accompany their partners to the health professionals' offices, you believe that they're in the office with you even when you've told them to sit outside. because they want control over what happens. There are some research on the dynamics of perpetrators. I've divided them into 3 major groups. The first is the kind of group that we work with a lot. We call them power and control batterers. They're the ones that the courts often send into treatment and 6 to 12-week treatment programs, which may or may not help them understand that getting power and control and using it in those ways is simply not appropriate, and it will cost them their relationship eventually. However, while they're getting their needs met, they don't stop. We also have mentally ill batterers. Most of them also are looking for power and control, but some of them have various forms of mental illnesses, and those 6 to 12-week offender-specific treatment programs are not going to stop their abuse. This also includes sex offenders, and it includes substance abusers. I might say a word about the sex offenders, which we'll talk about a little bit later, because there are a high proportion of these men who are also inappropriately sexualizing their children, and especially after the separation and termination of the relationship. And we want to learn how to identify them and protect the children. And then we have a small percentage, some estimate maybe about 20%, of what we call the antisocial personality disordered violent criminals. Many of them have on some of the tests that we use could be also labeled psychopaths. And these are men who rarely are going to be helped by our treatment program. In fact, there's some evidence that suggests if they are true psychopaths, psychotherapy is going to make them better in terms of their violent behavior rather than stop it. An interesting research study was done about 10 years ago by Neil Jacobson and his colleague at the University of Washington in Seattle. He was looking at assessing batterers from the types of behavior and power and control that they used to control their partners. And he ended up calling them cobras and pit bulls. The pit bull is the kind of person that we often think about when we think about what is a batterer like. They're more dependent, more impulsive. They really have almost an engulfing type of intimacy in their behavior because they fear abandonment. They think that they're very vulnerable, and sometimes he even thinks he's the victim. It's a very distorted self-view. They may also be more passionate, but at the same time, they want the woman and the children sometimes to themselves, so they may have more isolation. And when they get angry, their anger causes their heart rate to go up, and the anger builds and builds and builds until it explodes. On the other hand, there's another type of batterer that Jacobson called cobras. These men are much different in that when they get angry, their heart rate actually goes down rather than up. They are controlling and intimidating, but with a kind of cold anger. You know that they're angry, but they're not raging and they're not seemingly losing control. In fact, they're even taking more control. They have more of a push-pull type of intimacy. One minute they get very intimate, then they get scared and they pull away. They are emotionally abusive, and most of the women who are involved with cobras say they are more frightening to them than the pit bulls. They sometimes even have macabre charisma. That is, they sort of make you want to be with them because they're so charismatic. But the minute you get close, you see there's something really wrong here. They are the hardest to leave. They choose their partners. Like a cobra, they lie in wait and plan and then attack. They're more independent, less dependent than the pit bull, and they have, as I said, a lower heart rate when they get angry. So, knowing that, we know now that there's a broad type of batterer who might present to you. Who are the victims? Well, again, gender tells us that most of them, even though not all of them, are women. They cut across all demographic groups also, and all educational levels. Some of them are passive and fearful, but not all. Some of them are very strong in their important jobs, but not in their house. Some of them are even bullies to other people. Some of them you could tell that they were bullied, but you don't know that they're also being abused. Others, you wouldn't have a clue that they're being abused in their home. Many of them are isolated outside of their work, but they don't talk very much about their home life to the other colleagues on the job. Most of them are excellent patients because they're very diligent, thoughtful, and compliant with authority. They don't want to make anybody in authority positions angry. If their partners interfere, they will not be compliant with health care. So they may be pulled out of treatment if their partners find out. Sometimes these victims will come for treatment and not tell him. Then you and the person must develop an elaborate plan so that neither your phone calls nor your mail will go to the home. Well, how do you know whether it's domestic violence or not? First, the most important thing is to ask directly. In every intake, you ask if the victim or if the woman who you see is being abused. You may also want to ask a man if there's domestic violence in his home as well. If you see visible bruises, document them in your charts. If somebody misses appointments and they're in an erratic way, document that. Some battered women show fearfulness, nervousness, and anxiety. Others do not. Some come in, they're very depressed. Others do not. Some of them may make behavior changes, and you need to find out why. And some of them will make excuses for a controlling partner. Others may not, but simply may be stuck. And some of them may abuse substances, and some of them may not. So most importantly, and I'm going to say this a number of times, do not make leaving the batterer or terminating the relationship a goal of treatment. It is not. The goal of treatment is to live in a violence-free life. We also need to screen. As I said, you want to be able to ask every one of your clients who come in whether or not they have been involved in a relationship where there's been domestic violence. Straight out. You want to be careful because of cultural and socioeconomic sensitivity. Nonetheless, we still want to ask. You also want to be sensitive to gender inequality, although there are certainly lots of media that talk about gender equality. We know that many people still live in homes where there is gender inequality. Not all of those homes have domestic violence, but some of them do. We want to make our decisions about whether or not there is domestic violence based on multiple data sources. In forensic psychology, we're always talking about use more than one way of asking the question. You may ask in an interview. You may use a psychological test, for example, the trauma symptom inventory, the detailed assessment of post-traumatic stress, or some of the other tests that are available. You can even use some of your own screening instruments, but make sure that they're sufficiently complex to capture what we're looking for. Try to have some feedback loops to check for errors in your data. Ask the client. The client is always the best source. Recommendations should also be checked for the dangerousness. It's nice to say our client should do something, but if they feel that that will get them more abuse, then we don't want to make that recommendation. And we also want to remember that when the client is still with the batterer, family treatment is simply not part of the protocol. It will upset the system and it could make it worse.